programs that are going in colorectal. She has been involved in the CDC. She has been involved in a lot of the society groups that come up with the new recommendations for where we are today as far as colorectal cancer screening. So we are super excited to have you here. I know it's been a long road. We've had a lot of emails, and we welcome you. Thank you.
Thank you so much. Can you all hear me okay? All right. It's a pleasure to be here. We had some travel issues, but I'm here and it's sunny and it's beautiful and I'm really thrilled to join you all today. Thanks for coming and for joining online. Before I get started, I just want to thank the American College of Gastroenterology who sponsored my visit, this opportunity to visit and be with you all through this Edgar Acker Visiting Scholar in Equity, Diversity, and Equitable Care. Here are my financial disclosures, not necessarily pertinent to this presentation, but for transparency. So the outline of my presentation, I'll first kind of walk you through the current impact of colorectal cancer in the US as we understand it. Try to paint a picture that links social determinants of health to disparities in outcomes that we observed. And then I'm going to provide you a framework for how our lab tries to tackle these issues. And I'll highlight, we have work that spans research, quality improvement, medical practice guidelines, as well as public policy, but I'm really going to do a deep dive on the research and quality improvement piece, and I'm happy to take questions on any of these aspects at the conclusion of our time. So before I get started, I always acknowledge the places that I have trained and have really informed the work that I do. So these are all safety net hospitals, and safety net hospitals and FQHCs represent about 25% of hospitals in the United States, and they provide care to individuals regardless of their ability to pay. So Komen Home and Health is a federally qualified health center on the south side of Chicago, where I was fortunate to rotate as a third-year resident, which was when I began to understand the disproportionate burden of colorectal cancer in Black and Latino communities. And then I went on to do my fellowship at UCSF, where I had the opportunity to work at the now Zuckerberg San Francisco General Hospital, which is our safety net there, and began to explore a lot of the research questions that we continue to ask today. And then finally, Harborview Medical Center, which is the safety net health system in the Seattle area affiliated with the University of Washington, where a lot of our studies and work is often executed. So colorectal cancer is a leading cause of cancer deaths. This year, it is estimated to be the second leading cause of cancer deaths in the United States, with an estimated 53,000 people who will die from this disease. So maybe you all are familiar with this. This is the Tropicana Stadium here, and Tropicana Stadium at its maximum fills about 49,000 people. So just to give you a visual, you would need to fill the stadium to its entirety, and there would be people outside. That's the impact of this disease in this year alone. And colon cancer is thought to be largely preventable, one of the most preventable cancers, in fact, because of the myriad of screening tests that we have. But unfortunately, 42% of those who are within the eligible screening age, so 45 to 75, have never been screened. And the number of people who are turning 45 and 49 is increasing yearly. Already that pool is about 20 million people, and about 4 million people are getting added to that pool yearly. And in 2030, it is estimated that it will be the #1 cause of cancer deaths in men and women under the age of 50. So just to sort of show you the changing epidemiology, and you've probably heard a lot about colorectal cancer in the young. We know that colon cancer also doesn't affect all groups equally. Unfortunately, Black and Indigenous populations have the highest incidence from colorectal cancer. So here in the teal bars, I'm showing you men and women combined, and you can see that for here we go. All right, so for men and women combined, when we look at Indigenous populations, non-Hispanic Black populations, that those have the most highest deaths from colorectal cancer per 100,000 in the population. And for the very first time ever in the study of epidemiology of colorectal cancer, American Indian Alaska Native populations actually now have the highest incidence of colorectal cancer compared to any other racial and ethnic minority group in the United States. So approximately 30 to 40% of Indigenous and Black people who are diagnosed with colorectal cancer will die compared to their white counterparts. And it's not just race alone. So when we look at, the incidence of colorectal cancer and death, when we sort of overlay on top of that, people who live in urban versus rural areas, and also overlay persistent poverty. And persistent poverty is defined as where you have more than 25% of people who live in a county who live at or below the 100% poverty rate. So when you overlay all of those kind of factors, you see that there is the highest impact of disease really in the southeastern corridor of the United States, where we're standing right now. And so that really starts to paint the picture that it's not, race, but really the conditions in which people live that influences their outcomes when it comes to this disease. And so this is what we call the social determinants of health. So these are the conditions in which people are born, live, grow, age, and ultimately die. That really helps to influence and shape their health. And we kind of think about this in a few different ways. So upstream social determinants of health are really the policies and the programs that might exacerbate social inequities, which could be defined by race, ethnicity, class, gender, or sex. And I'll give you a very specific example moving forward. Midstream factors are then the environments that people live in. And so when you have policies that then, for example, lead to increased pollution in an area, then that's the environment somebody lives in that may increase their risk, for example, for cancer or for COVID-19 or for other diseases that we often tend to focus on in research and policy, when really we should be kind of looking upstream and seeing what are the things that have led to poor health outcomes. So here we are in Tampa, and this was the headline from the Tampa Bay Times. This was in 2018. And what they said was there was a study that found that Tampa Bay homes that had been in historically redlined areas. So the redlining was a policy by which mortgage companies would use to determine what they thought to be hazardous neighborhoods, such that the banks would then not provide mortgages for people who lived in those areas. Really, this was a proxy for race because oftentimes those areas that were deemed hazardous tended to be predominantly Black. And so this particular study found that, even long after repeal, that homes that were historically in redlined area in the Tampa Bay were worth less than half the amount of houses that were not in non-redlined areas. So pretty significant, right? And when we talk about generational wealth and the ability to pass on homes and for individuals to accumulate health, to get better education, better access to healthcare, this is sort of direct evidence that this is still having ongoing effects long after these policies have been repealed. I found this quote really, this is what we know to be true, but it's reassuring to hear people in leadership mention this. And so here you have the chief economist for Zillow, who says the lasting impact of redlining is a striking example of how the kind of discrimination, financial and racial, codified nearly a century ago, continues to affect homeowners and whole communities today. So ultimately, all of this sort of comes together, and we see that as a result, Black people tend to have higher mortality from many cancers. In addition to colorectal, Black people are about 36% more likely to die from breast cancer. They are 2 times more likely to die from prostate cancer, and 30% more likely to die from cervical cancer. And when we look at colorectal cancer specifically, colorectal cancer is seen on a continuum. And some of you might be familiar with this figure by Isaaka et al., where they sort of describe all these multiple steps that need to happen for somebody to go through the colon cancer screening process. And it starts really with, assessing their risk, trying to prevent disease, all the way to surveillance and survivorship. And I'm going to highlight 2 areas that our group has tried to make an impact in, which is in really trying to bridge the gap in the failure to screen step, as well as the failure to follow up abnormal results. And just as a framework for how we try to address and improve CRC outcomes, our lab's mission is to reduce the burden of colorectal cancer and other digestive diseases, particularly amongst racial and ethnic minorities and people of lower socioeconomic status. And so we do this by partnering with safety net healthcare centers where there is a critical mass of these populations who are coming to receive care. All right, so first I'm going to describe our population health. And as I mentioned, I'm going to highlight our areas of research and quality improvement. The first one is going to be around quality improvement. So this is our population health colorectal cancer screening program. So I joined the faculty of the University of Washington and Fred Hutch in 2017. And at that time, there was immense interest in understanding who was the catchment area for that hospital. Not sure about your health system, but ours is an open healthcare system. Many people can come and leave as they so please. And so sometimes it makes it a little hard to define who is truly owned by the healthcare system versus who is being seen elsewhere in community. And so we worked, collaboratively with the internal medicine and other primary care groups to really define a metric around colon cancer screening. So the description was at that time that it would be the percent of adults who are 50 to 75 years old who had had an appropriate screening test. We had to define the numerator as at least patients who had received at least one colorectal cancer screening test. The denominator, because again, we're in an open healthcare system, we defined as people who are 50 to 75 who had had a primary care encounter in the past 3 years. And an encounter could be an in-person visit, it could be a lab draw, it could be a radiographic study, but just something that tied them to the health system for the past 3 years. And we thought that if they had done those things in the past 3 years, they were more likely still receiving care from us. And then we excluded people who had advanced comorbidities, history of colorectal cancer, et cetera. In going through that exercise, we identified that there were about 84,000 people who were within our healthcare system and were deemed eligible to be screened for colorectal cancer, but only about 55% of them were actually up to date with screening. And even then, the National Colorectal Cancer Roundtable had set a national goal of 80% screening, as this is the critical number thought to be needed to be achieved to substantially reduce the ongoing mortality from this disease. So, to kind of pivot a bit, we know that stool-based tests increase colon cancer screening participation. Many of you are familiar with the fecal immunochemical test, which is the newer generation of the fecal occult blood test. This is the one sample screening test that detects blood in stool. And it's actually the most used test for colon cancer screening globally. And here in the United States, it's preferred for hard to reach populations. Our work demonstrated that when this test was mailed, that you could actually increase screening participation by an average 22%. So again, I'm showing you data from UW-Medicine. The red box highlights the groups combined. So UW-Medicine is sort of split into 5 medium to large groups. HMC is Harborview Medical Center, that safety net population that I mentioned. And so when we started in 2017, we used mailed FIT as an approach to help improve colon cancer screening across the health system. In addition to partnering with primary care, setting incentives, and really trying to evangelize the word about the importance of colorectal cancer screening. And using a combination of those strategies, we were able to improve colon cancer screening by about 16%, from 55% to 71% over a 1.5-year time period. Then COVID happened, right? And everything sort of paused. CMS said, we can't do non-urgent procedures. We saw, plummeting rates of colon cancer screening nationally, including in our healthcare system. And I would say that overall, we were actually pretty fortunate that our rates did not drop, even further. But where we had seen great gains, so for example, within our safety net healthcare system, where initially only 39% of people were up to date with screening and we went up to 55, we were starting, to become really concerned about this group in particular, because as you can see, when I showed you that 71%, not all groups were there yet, right? So work that we did during the COVID-19 sort of pause was a modeling study that I led. And we, sort of modeled what different scenarios might look like. So here in this first scenario, we just show what life would have been like without COVID, right? Distant past, that's not what life was like. And then in that very first quarter of 2020, things were kind of operating as normal. In the second quarter of 2020, that's when CMS hit the hard pause and all of the screening tests stopped. And so from there, we modeled different scenarios. We knew that it would take people quite a bit of time to become comfortable completing colonoscopy again. And so we said, well, what if, it takes like about a year and a half to get colonoscopy back to about 50%. And then afterwards, you slowly begin to ramp up. We modeled a different scenario. We said, okay, what if that slowdown occurs over a longer period of time, over a year, like almost 2 years instead of this first scenario. And then we added scenarios in which you increased FIT-based testing. So at the time, about 15% of people who completed colon cancer screening in the US used a stool-based test, primarily FIT. And so we said, what if you increase that to about 21% using these modeling strategies? And what we showed was essentially you would be able to screen an additional almost 650,000 people and detect an additional almost 2,700 cancers, of which 71% were early stage, if you improved or increased FIT use during these prolonged periods of decreased colonoscopy use. And so really armed with this information and also with our prior experience in being able to really impact colon cancer screening across our health system, we approached leadership and really lobbied for a population health CRC screening program, which thankfully we were able to then establish in 2021 as a joint effort across our cancer center, as well as our teaching academic community practice. And so the mission of this program is to improve CRC screening completion for all UW-Medicine patients, because remember, the Hutch is a cancer center similar to Moffitt. So by that point, it's a bit late. We want to catch people before they're diagnosed with cancer. And we wanted to make sure that everybody had equal opportunity to participate, so we could start to chip away at these disparities that we saw by different groups. And the impact was that we expected the program to improve patient care quality, increase care equity, and we know health systems really care about additional payer contracts. So we wanted to make sure they were aware that that was a possible outcome as well. We had in fact demonstrated that in the initial demonstration work. So this is the program now in its existence. We are just in our third year. We, in our first year, oversaw a mailing of FIT to over 10,000 people who were part of our health system, who were not up to date with colon cancer screening. In the second year, we outreached about 15,000 people, and this year, I think the number is around 20,000 individuals who are receiving mail FIT as part of this program. So it's a collaborative relationship with people across our institutions, and I'd probably say the two most important people on the team are Amy and Jerry, who are panel navigators who are intimately involved with helping patients receive the test, complete the test, and help them get the colonoscopy when they have an actual result. So when we were kind of organizing this, again, because of my research background and wanting to use a very systematic approach to developing this, we tried to document everything. We tried to incorporate best practices. We worked with primary care and the institution to define the approach. We determined who the target population would be and what the method of screening would be. We identified the team that was responsible for implementing, as well as the healthcare team that was responsible for the decision-making. And then we have a quality assurance structure and then also a way of detecting cancer. So just to give you an example of the workflow, eligible people are identified. We work with our Department of Lab Medicine and Pathology. They actually order the tests. And we then work with a different group within our health institution that is responsible for putting the packets together. These packets get mailed out by about 1,000 per grouping on a weekly basis between March and June. And as the director of the program, I'm the one who's signing these orders. So we have a bulk order feature in Epic, but it's linked to their primary care doctor. So the letter that actually goes to individuals is signed by me and their primary care doctor. The results go back to their primary care doctor. Our team is on the background sort of tracking. And if patients, for example, have an abnormal result and haven't completed a colonoscopy within a month, then our team will step in and say we can help. And patients have a direct line to call that individual to help them with scheduling. Our navigators have also received training on how to directly schedule within GI practices, so they can directly schedule people for colonoscopies who have an abnormal result. And this has been sort of each year we iterate on this process based on the feedback we receive from partners. So this is just showing you sort of the first year of outreach. I get mentioned about 10,000 people who received outreach, about 31% completed it. And then we had about 31 patients who were found to have either colon cancer or with high-risk lesions, which was about 7%. So higher than what we see nationally, but this is an unscreened patient population. And I always kind of show this comparison because you sort of hear 30, and I think ours was actually 32%, but you hear 32% and you're like, geez, 10,000, only 32%, completed it. I always highlight that these are people that were not going to be in touch with their healthcare system. So now it's either you have 32% of what would have originally been zero. And compared to other similar screening programs that have been published nationwide, you can see that in our first year, we were on par or exceeding those other programs. And actually in our third year, we're up to now 36% of people who complete screening, and they are doing it faster because they have now been primed to do this. This is just a brief kind of snapshot of, where things started and where we are. I mentioned that, COVID impact, right? We dropped to 68%. And you can see that year by year, we're slowly creeping back up and we're getting closer to that 80% goal. We still have work to do though, right? I mentioned the safety net system. So we had that decline, again, associated with COVID. And so we're really focused intensely on this group and how can we bring them up to the same CRC screening completion as the rest of these groups. And I'll show you a couple of things that we're doing to address this challenge. So first, we had a lot of patients within our safety net healthcare system who were initially refusing to participate in the screening. They were really concerned about associated costs that they would receive out of pocket by participating in this program. So we were able to allocate a portion of the funding that we received for this program towards patient assistance. And to date, we've been able to, I think this number is now over 100 underinsured or uninsured individuals who have been able to use this resource. Keep in mind that the test itself that they're receiving is free because it's provided through the Department of Lab Medicine and Pathology. But what they're worried about is like the cost that may be associated, for example, with the lab processing the test and given the results. And then we've had patients who've been diagnosed with colon cancer. And because we have this joint partnership with our cancer center, we're able to plug them in with financial navigation that would normally happen through the cancer center to help them get to the completion of care and treatment if needed. We also expanded our language access materials. And so when we first started, we were only providing materials in English and Spanish. When we looked at our safety net healthcare center, in certain clinics, only about 32% of individuals actually spoke English. And we noticed that those individuals were not participating in screening. So we've since translated our materials to 9 other languages, and the materials include a letter that goes out with the fit kit that sort of explains what screening is, who is appropriate, who is not appropriate, and provides a direct number for them to call us. The materials also include epic messages that we kind of bulkily send out to individuals saying, hey, you've received a fit kit in the mail. This is your reminder to complete it, as well as text messages and videos that we've created that demonstrate how to create a fit. And so those are now all available for these individuals who speak different languages, and over an additional 500 people have now completed screening using these materials. We measure impact in many ways. So yes, we want to see improvement in screening. Yes, we want to see groups that have historically not been as up to date with screening do better. But we believe that a large part of getting groups to participate in screening is by engaging them and trying to help reinforce the importance of screening. And so our program hosts an annual colon cancer community awareness event. We do this in collaboration with several community partners. We just had this year's event in partnership with our First African Methodist Episcopal Church in Seattle. And we always sort of ask entry and exit questions. So this is just an example of last year's entry and exit question where we asked people if they knew the age at which to begin colon cancer screening, and the knowledge of attendees doubled before and after participating in this event. And then we were really pleased. The state of Washington produces what's called a Washington Health Alliance. The Washington Health Alliance is in the state and it produces a report every year. And it's really a report card on how the state is doing when it comes to overall healthcare. And they look across multiple healthcare systems, claims data, pretty much any data that they can find, and will say, you know, how institutions are doing when it comes to breast cancer, immunizations, colon cancer, et cetera. And and again, this is amongst commercially insured. So I always like to kind of highlight that. But it showed that our site, the University of Washington Medical Center, had the highest rate of colon cancer screening in the state of Washington. So 88% of our insured population was up to date with colon cancer screening, where the 90th percentile national benchmark was at 72%. So again, we're trying to mimic these results in the uninsured and the underinsured populations as well. And, you know, for those who, you know, see this work and they're like, but you haven't addressed the disparities yet. I just want to highlight that this is long work, that this is, you know, really forward looking and it takes some time. But when I see data like this coming out of Kaiser, I'm really encouraged. So Kaiser, over about a 20-year period, by continuing to use mailed fit tests. So essentially when people turn 50, they receive a test in the mail that says, happy birthday, it's time to screen for colon cancer. And by doing that, they were able to reduce overall deaths from colon cancer across the health system, but specifically, they were able to reduce the disparity in deaths from colon cancer between Black and white populations. So going from about 21.6 per 100,000 cases as the initial difference between Black and white individuals to 1.6 per 100,000 as the difference between Black and white individuals. So again, this is possible. I think health equity using these strategies is achievable, but as I reinforced to the team on a consistent basis, that this is not going to happen overnight, and we need to continue our efforts moving towards this goal. So now I'm going to switch gears and I'm going to tell you about some research that we're doing, trying to address the specific problem of lack of follow-up after a non-invasive colon cancer screening test. So we talked about FIT as one strategy. There was a recent paper that I'm a co-author on that came out in New England Journal of Medicine, which is the first blood-based test for colon cancer screening. And so all of these non-invasive tests are two-step screening strategies, right? So if there's an abnormal result, then you have to get a colonoscopy. But we know that that does not always happen. So this was an attempt to address that specific issue. So here I'm showing you data from a systematic review that we did looking at colonoscopy after abnormal stool-based tests. And what you can see is, regardless of the healthcare setting, whether you're at QHC, integrated health system, VA, or, regardless of the type of test you use, whether it's a FIT, FOBT, or the multi-target stool DNA, that these numbers are low, right? So starting from about 33%, the highest we see is about 84%. And this is again within Kaiser, which I always say is a different sort of environment because it's a closed healthcare system. So the goal would be 80% of those who have an abnormal result would get a follow-up colonoscopy. And you might say, why not 100%, right? So we know that there are some people who are not really appropriate for FIT, but get it anyhow. And those individuals are never going to go on to receive a follow-up colonoscopy. And then we also know that individuals' health statuses might change by the time they do a FIT to when they might need a colonoscopy. So that number is not 100%, but we know that for those who have an abnormal FIT, who never get a colonoscopy, they are 2 times more likely to die from colon cancer over their lifetime compared to their counterparts that do get a colonoscopy. So it's really, really important that as many people in this group get that follow-up test. So when I started, exploring my work to fund my career development award, I looked at what interventions existed to really address this particular problem. And this was a really nice systematic review by Kevin Selby, who pretty much showed that regardless of the level of the intervention, whether it was at a patient level or a provider level or a system level, or whether it was a randomized test or non-randomized test or maybe some other trial design, that the number of studies that existed evaluating interventions to improve colonoscopy were exceedingly low, right? So you can just see that these numbers are 5 or less, essentially. What was also interesting was that the research studies often included symptomatic patients who we know are different. And oftentimes there were multiple interventions and they were not disaggregated. So it's really challenging to understand what the specific intervention effects were. And then the third point I raised is that most of these studies actually came from VA populations. And so when we talk about safety net populations or integrated health centers, there wasn't much evidence there at all. So this really led to my career development award, which I'm currently on. And what we hypothesized is essentially the factors that influence follow-up colonoscopy after an abnormal FIT are different than those that might influence initial screening. Because here you have a population that has said yes to screening, but then says no to doing the second part of that screening test. And so we wanted to use mixed methods, so quantitative and qualitative tools to help identify modifiable factors that were at the patient, provider, and clinic level. And then also use those to identify a pilot intervention to address this particular challenge. So in some of the work that we did, so these were interviews we did with providers, so qualitative work, we found that the most reported barrier in safety net populations to follow-up colonoscopy completion was lack of transportation. So reported by almost 57% of those who we interviewed. Or I should say, and then the number 1 and 2, and the other one being the cognitive factors, so having challenges with the bowel preps. And even across safety net centers, we know that they're not a monolith. And so we've seen within our health system where some safety nets have about a 30 to 40% follow-up rate, others have a 70% follow-up rate. And so we try to ask those higher performing clinics, what are the things that are working well for you? And they told us interpretation when available, and also patient care coordinators, because they were really sort of extensions of those clinics. We then, again, trying to use all of the available tools to get at why this was an issue, use electronic health records to see if patients who had an abnormal fit, if there was anything documented in their EMR. And what we found was overwhelmingly the most only about 40% of patients had a documented reason. And the most common documented reason was that they declined the colonoscopy without additional details around why patients declined the colonoscopy. And then you can see some other kind of reasons listed here. So we did this exercise of then matching patient interviews with patient electronic health records, trying to see if what was listed in the patient's chart actually matched what the patient said when you asked them about why they did not follow up. And so these are just some examples. The different colored bars, so the teal bars are kind of showing you the proportion of patients when interviewed who gave this response. The dark blue is showing you the proportion of these answers that we found in the electronic health records. So giving you as an example, lack of transportation was only documented as a reason in the EHR about 5% of the time. But when we asked patients, almost 20% of them said that lack of transportation was an issue and why they failed to follow up. And in the EHR, there would be a statement like the patient will ask brother for a ride home. And then the patient said, my brother lives near Canada. It's pretty far away. So essentially he had no intent of following up on that colonoscopy. So this is, again, a type of research methodology. It's known as mixed methods. So this is convergent parallel mixed methods, where you're trying to kind of like bring different pieces of information together to get at a fuller picture of what might be happening. Ultimately, between the work that we did and our systematic reviews, we found that there are three main buckets as to why patients, providers, and EHR might say that somebody didn't do a follow-up test. So logistical, because there were multiple steps to colonoscopy and lack of transportation. Personal, so fear of the colonoscopy or cancer diagnosis, and then concerns about the bowel prep. And then financial, lack of health insurance and out-of-pocket costs, even with insurance. Financial barriers are pretty challenging to overcome. And there have been lots of studies that have looked at whether if you incentivize individuals, whether it's like, let's say $50 guaranteed or a lottery with a chance of winning 500, that it really does not make a difference when it comes to colon cancer screening. And I think it really, because it comes down to the health insurance piece and people being uncertain about what their out-of-pocket costs will be. So we knew that that would be a pretty challenging barrier to overcome. But certainly, we thought that logistical challenges and the personal challenges we might be able to overcome. The logistical challenges we've addressed in part with the colon cancer screening program, where we've really tried to streamline the screening process and reduce those steps. I mentioned that our navigators work directly with patients who have not completed a follow-up within 1 month. So again, this is live person, they call, and the navigators in real time scheduling those colonoscopies. So that's reducing the steps. We have a project that's addressing the fear of colonoscopy. It's a video project that's funded by the ACG. I'm not going to talk about that today in detail, but so far the pilot results seem quite reassuring in our pilot randomized control trial of patients who are randomized to watch the video or not watch the video and are assessed questionnaires about fear, knowledge, and their self-efficacy before and after watching the videos. But I am going to talk to you about this intervention that we designed to specifically address the lack of transportation. So we hypothesized that rideshare non-emergency medical transportation platforms like Lyft and Uber, Lyft I took to get here today, are potentially scalable and cost-effective strategies to increase colonoscopy completion. As many of you know, most healthcare centers do not allow patients who receive sedation to get into a Lyft or Uber after completing the procedure. And so we first thought it was important to identify what the barriers, facilitators, and process recommendations might be if we wanted to implement something like this in our healthcare system, and then to pilot it. And really the primary outcome would be safety. So we used informal stakeholder engagement, and it actually kind of timed well because a lot of these meetings were supposed to happen in person and were just really happening right in the midst of COVID. So everything shifted electronically, and we had over 22 meetings with 34 individuals, ranging from patients all the way up to the Washington State Healthcare Authority. We use storyboards as a way to engage stakeholders. And so these are, so using figures and illustrations rather than make PowerPoints, because we had people from the rideshare company who were present and, other stakeholders who didn't necessarily care too much about, a lot of the research data per se that we might want to share. And then we had 5 stakeholders who helped finalize the workflow. So through this process, we were, and I should also mention, there were a lot of meetings with legal, lots of legal and risk management meetings, as one might imagine. But through this process, we were able to reach an agreement between our healthcare center, the legal team, and Lyft. And we developed a contract that would allow us to use rideshare for this exact purpose. So this is the workflow. So within our safety net, because again, that was where this issue was the greatest. The endoscopy staff already had a workflow where they asked patients when they're scheduling colonoscopy if they had a ride or somebody to accompany them. So we said when they identify those individuals to send them to our team. Our team would then contact individuals and explain that this was a study. They provide informed consent. They complete a baseline survey. And then we give that information back to the endoscopy unit. On the day of the procedure, patients complete their colonoscopies as scheduled. And the discharge nurse then accesses this Lyft concierge platform. So patients do not themselves need to have a smartphone. The nurse or whomever's discharging calls the ride for the patient, and the patient cannot change the final address. The patient doesn't receive a bill for this because they're not the ones who initiated the ride. And the nurse would often accompany patients down to the front to get into the lift. So that was the chaperone. So it was sort of using an unaccompanied strategy, whereas these patients would historically just sit in the endoscopy unit for hours on end, taking up a space that then could not be used for another patient. 1 to 2 weeks later, patients are then called by our team. They complete a survey detailing their experience. And I should also say that in real time, multiple members of the team are tracking patients because on the concierge, you can see when people leave and you can see when they are dropped off. So we can track them in real time and then we call them afterwards to also find out about what their experience. And then we can get information from the Lyft platform backend on cost, distance, time, etc. So to date, we have over 100 patients who have used this particular service. When we started, because again, legal and anesthesia concerns, we initially said only people receiving propofol could use this. After the first probably 40, when we demonstrated safety, like no issues whatsoever, we then expanded it to propofol patients. Initially, we were just at our safety net. We are now across our main university campus, as well as the safety net health system. Majority of patients so far have been men, primarily speak English. 50% white, 23% Black, 11% Asian, 4% American Indian Alaskan Native, and 16% self-identify as Hispanic. You can see that most are either Medicare or commercially insured. There was initially a lag in Medicaid injuries because the state healthcare authority was very concerned that we would be double dipping and they could get in trouble legally. And we said that's not what we're doing. We're just giving people another option. So then we were able to enroll Medicaid enrollees. So those are probably the fastest growing population in this work. The average ride costs about $35. Average distance is about 7 miles. And the average length is about 18 minutes. And you can see that most people actually live within 30 minutes of the healthcare center. Getting to the procedure was not their problem. It was the getting home part. So that's what this intervention specifically addresses. And it was initially funded through a grant through NCI. And that grant ended, and now this is supported entirely through philanthropic donation. So, and then again, we interview patients afterwards. 100% of patients got to their destination safely and said that they would use it again and would recommend it to others. The key barriers when we do our thematic analysis of our interviews that this program has helped them overcome includes access to the procedure. Patients said that they would have rescheduled or just canceled their colonoscopy, and autonomy, so not having to rely on somebody else to get to their healthcare needs. And then these are just some representative quotes. Patients said they didn't have to depend on somebody to take the day off of work to be with them. Somebody said it works. There are people like me who kind of fall between the cracks. We don't have any kind of support system, and just having rideshare made a difference. So I might go into how this kind of ties up in the end, but the bottom line is that there are multiple barriers at multiple levels of care that leads to inadequate follow-up colonoscopy. And so this work has really helped us identify what those barriers are, and we've now developed interventions to address them, right? I mentioned for streamlining the screening to follow-up process, we now have a population health program. For the transportation barrier, we have the rideshare, and for the fear, we have this video that addresses fear. And so all of this work has now informed an R01 application that's proposing to test these multiple interventions that address multiple barriers, multiple levels of barriers in a safety net health system and comparing that to usual care to see if that can lead to dramatic improvements in follow-up colonoscopy completion. So send positive vibes for a good review so we can in fact get funded to do this work. I'm going to briefly touch on some of our team's contributions to medical practice guidelines and health policy. And I think this is important because, you know, we can do great work, and I think a lot of us do great work, but it's hard to really affect change on a population level unless you're able to affect the practice guidelines and policies that kind of guide how people are triaged within health systems. So to say if you are invited to participate on something that helps direct guidelines, find a way to please say yes, because I think it's immensely important. I've been fortunate to be a member of the National Comprehensive Cancer Network panel that helps write the colorectal cancer screening guideline practice guidelines for the past few years. And it's been a really fulfilling and interesting process because as updates are coming from example, when the American Cancer Society said, let's reduce the age to 45, then we're saying, is that what we want to do? Having a conversation around that as new evidence comes out around new tests, figuring out how to integrate that into these guidelines has been a really fascinating learning process. And then I also had the opportunity to join a CDC sponsored summit where we really just outlined Meals Fit, as I highlighted, can really improve screening participation, but can be very intimidating for a lot of health centers on how to implement this. And so we really wrote this how-to guide for institutions that are interested, thank you, that are interested in adopting this in their settings. At the state level, I've had the opportunity to join a Washington state created coalition that was kind of started by the state legislature, and we then provided recommendations to the state legislature of what Washington state could do to improve colon cancer screening. In my ideal world, there would be a national cancer screening program, right, where you might be able to go in and you could see your patient that moved from, you know, Texas, even though they're here with you now, that they have completed screening, but we don't have that. And so in lieu of that, we proposed to the state that we in Washington can begin something like that. In the same way that we track vaccinations for children, we should be able to track screening for adults. And that would be really important for capturing the uninsured patient population. We'll see what they take with that recommendation, what they do. During COVID-19 and sort of when screenings were paused, I had the opportunity to join the President's Cancer Panel to give advice on how we can begin to mitigate the impacts from COVID-19. And a big strategy was really the modeling work that we did on how if you improved and increased FIT use, you could potentially offset some of these upcoming mortalities that have been predicted to occur. And then lack of follow-up and insurance coverage has been a major issue for many, many years. For years, through the American Gastroenterology Society, we would go to DC and just continue to lobby because there were people who would, you know, ACA said you must cover screening. And essentially what would happen would be somebody got a colonoscopy, they were covered, but if somebody got a FIT and it was abnormal, then the insurance companies would say, well, you already got your FIT, we already paid for that. So we're not going to pay for the follow-up colonoscopy because that's a separate test. And so we really lobby that these are in fact connected and they're the same screening process. And back in 2022, through a partnership between CMS and the Department of Labor and the Treasury, the AGA with Fight CRC and the American Cancer Society Cancer Action Network were able to get a rule passed that said that any insurers must cover follow-up of abnormal non-invasive tests without cost sharing. So now this is legislation. So these opportunities might seem, you know, initially burdensome, or you're sort of like, what am I doing here? But I highly encourage you to consider participating because over time, I do think that it impacts policy, and then you can, you know, kind of share that with your patient. You know, this is no longer a cost you have to bear. So in conclusion, colorectal cancer outcomes have improved dramatically since the 1970s, but disparities exist for specific groups. I personally believe that addressing social determinants of health really can improve outcomes disparities. And in our work, we try to do that by, again, making the test accessible to people at home. So they don't ever have to leave their home if they don't need to, and also helping them get transportation to that follow-up. So we, there are multiple other social determinants that are at play that I think we can all, kind of make contributions to addressing. Improving complete screening, so the follow-up, is really a natural extension of cancer prevention. And when I work with my primary care colleagues, I, sort of say, when we discuss non-invasive screening strategies, we need to tell people that this is a two-step screening strategy. So if you choose to do this non-invasive test, just know that if you have an abnormal result, you're going to need a colonoscopy. And I don't think we've always done a great job of that, which is why people sometimes get surprised when they're like, what do you mean I need a colonoscopy? I already did my cancer screening test. Interventions that target multiple barriers are needed. And I think it's because, and especially in safety net settings, there has been a lot of work around navigation and of how navigation can help improve screening and maybe some early signals that it might improve follow-up as well. But what we see from the literature based on those follow-up rates I showed you is that navigation alone has not gotten us to that 80% goal. So we need to figure out the multiple strategies that address the multiple barriers that patients need. And that's really what our R is proposing to do. And I'm a strong believer that a combination of strategies, including research, quality improvement, medical practice policy, are all really critical to moving the needle to achieve health equity in colon cancer and beyond. So thank you. I want to acknowledge my funding sources. I don't do this work in a vacuum, so I'm really grateful for all the teams that I get to work with. I mentioned our community partners, which are so critical in the work that we do. You can see we work here with like the public health offices of Seattle and King County. And then just a special shout out to ACG because this is the award that has funded our work to create these videos. And it's recently been renamed to the Leonidas Berry Health Equity. And he was the first Black gastroenterologist, Black male gastroenterologist. So now this award has been named in his honor. When I applied, the award was about $50,000. They've now increased it. So for anybody out in the audience who is looking for grant funding to do their work, I recommend you explore this potential award. Thank you so much again for the invitation and for your attention.
Take some questions for Dr. Isaaka, but I wanted you all to, and you, Rachel, the American College of Gastro and also the American College Gastro Institute for Clinical Research and Education and the Center for Leadership and Ethics and Equity wanted us to recognize her for her work that she has done. She's one of a few physicians who have been chosen as the visiting professors for this professorship lecture that is going on around the world. And I also, so here, please, congratulations. Thank you. I also wanted to give a shout out to Dr. Shreya Narayanan, who without this, we would never have been able, Shreya, stand up, please. She did come in the meeting while you were here today. She helped us fill out our application and came up with wonderful reasons why we wanted you here. And we are honored and truly you're an inspiration. So the floor is open. No questions, nothing.
Yeah.
Dr. Vidyarthi.
It's a great talk, very inspiring. So I have two questions that, one is that have you tried to leverage AI? Because sometimes when, like your patient says, my brother is in Canada, he's not understanding what people are saying. And last week there was a publication that says that generative AI can help in comprehending patient, helping the comprehension.
Mm-hmm.
So is there any role for AI in your project, number one? And number two is for the ride share. Like some of the patients in your community, they don't speak English or Spanish. If the driver does not speak that language, the patient feels dizzy, things like that, or when he goes home. So is there any concern with that?
Yeah. I think the potential for AI to influence our work is immense. Whether it's, the example you provided of that particular study, all the way to just even assessing who should be screened based on their prior findings. We have started to use AI as a way to scan electronic health records for a different project related to surveillance and inadequate surveillance. And I'm hoping that if those results are promising, we'll be able to start using those tools for the screening work that we're doing as well. Related to your second question. So when I first had this idea around rideshare, I said, oh, wouldn't it be great if we could train a fleet of drivers on basic support? And those drivers would be the only ones that would come and pick up patients. And so if they were dizzy, then the driver was trained and could do it and it would be wonderful. And pretty quickly I learned in speaking with Lyft that they were not going to modify their, and so that was the first kind of hit. The other thing was we wanted to be able to provide a door-to-door service. So for example, leaving the hospital, but then straight to the patient's door. And we learned that Lyft has different products in different states. And in the state of Washington, that was not an option. Luckily for you, the state of Florida, that actually is an option for you, that you can use door-to-door through Lyft Health and Concierge. Throwing that out there. So what we kind of proposed was that these patients are being recovered, right? They're fully recovered before they're leaving the hospital. And in any other scenario, if somebody were dizzy or whatever it may be, then whoever's giving them a ride is just going to bring them back to the hospital. So that's what happens. And so for the patients who don't speak English, that's kind of just what the nurse tells them when they get into the vehicle. Like if this person is unwell, needs to come back, you can just bring them back here. But again, we haven't experienced that because patients are fully recovered before they're released. Thank you so much. Yeah. Sorry.
But cluster ends.
Wait, okay.
I have a question about the
Yes.
funding for the rideshare.
Yes.
Was that through the hospital? Like, was that like something that was done through like the?
No, that was initially all through grant funding.
Okay.
And then as I mentioned, we've now secured philanthropic funding to continue the work. I have work that I will be presenting at EDW, which is a cost effectiveness analysis, really trying to make the case that CMS should cover this because it's,
Yeah.
it's quite effective, it's cost effective.
Thanks for your great talk and thanks for flying all the way from Washington, all entirely across the United States.
On the red.
On the red eye. So it was very interesting data. You mentioned that about or over 50% of people actually declined colonoscopy after positive FIT test. Did you do any deep dive onto that one? Because usually when FIT tests are recommended, patients undergo, they have an understanding that if it were to be positive, they will need a follow-up colonoscopy. So why 50%? Or it included some other things that made them decline the colonoscopy?
Yeah. I don't know that everybody knows that they need a colonoscopy if the result is abnormal. So I'll show you, I don't have this data here, but in our population health program, when you just mail FIT, about 35% of those with an abnormal result will immediately get a colonoscopy. We then showed that with navigation, we can get another 16% to get the colonoscopy. So now you're over 50%. And then the remainder, it's a combination of competing health issues is the reason. So they have some idea they want to do it, but they want to address something that's going on more urgently right now. There are housing unstable kind of people or people who are unstable living situations. They're like, we want to kind of sort that out right now. And then there are people for whom the fear of the colonoscopy and what it's going to find is the reason why they're declining it. So we're trying to work on that fear population, but I think for those who have the competing health issues or are in transitions in their life, it's just really hard. And what our team does is every month we generate lists of people with abnormal fits, and the navigators continue to call those individuals every month for about a year.
Thank you so much for coming. That was so great. Do you think in terms of really achieving equity in the future, in your research, there's ever going to be a role for offering this patient population FIT or colonoscopy or all the options? Because the ideal, like when, we're counseling these patients, we do like to offer everything, tell them what they're eligible for, but of course, FIT testing is a good option, but yeah, I just can't help but think like, should these people, it would be nice to also be offering them colonoscopy and just how you feel about that.
Yeah, so I agree with you, Dr. John Nadomi, who was my mentor, still is my mentor. His work, you all may know, really demonstrated that people are more likely to participate in colon cancer screening if you offer them a choice. And this was work that he started at UCSF, so patients were offered a FOBT at the time or colonoscopy. So in our screening program, when patients get the letter, they are offered the choice of a colonoscopy or a FIT. But the letter just says, but here's the FIT if you want to do it now. And if you want to do a colonoscopy, here's the number that you can call to get it done. So about 3% of people who are included in outreach opt to do the colonoscopy outright. and then the other 32% opt to do the FIT test. I think, again, it comes down to convenience and what people are able to sort of make work. But yes, colonoscopy is always an option for them. And I think as, even these stool tests and other tests sort of come on board, we've already started to think about how do you incorporate those into more shared decision-making conversations, because that's a little harder to, deploy a population-based healthcare strategy. And that really then requires patient contact for that shared decision-making conversation.
Yeah, I'm one of the whole idea of ride shares we're here too, because I'm one of the point of contacts for patients who don't have rides or companions procedures. What were the barriers that you had to overcome for somebody for this unaccompanied patient who is willing to use the ride share? Because at the VA, or I don't know if it's a statewide process, but we are unable to discharge patients without a companion, right? So that's one barrier, and then not having a transportation is the second barrier. So, what were the barriers? What were some of the things you did to overcome that?
Yeah. One of the first things, because I'm guessing similar to you all, you have multiple sites and each site has its own set of policies. So we actually had to review all of the policies for all of our different sites, and we noticed immediately differences. So our main university at that time had language that specifically said patients are not allowed to use Uber or Lyft to get home after endoscopy. Whereas our safety net population, they didn't have that explicit language. It was just like, we expect that patients, somebody should have been contacted that is going to provide this individual a safe ride home. So that was part of why we actually started there. We, in one of our interviews for a related project, had a patient who paid someone, a random stranger, $40 to be their contact person. They were like, if I give you $40, can you give me your number? And doctor, will call you. You tell them you're my ride home. And we presented that. We're like, that's really concerning. This is the length that people are going to and not, to do this test or are not doing it at all. We also made the case for all institutions have an unaccompanied escort strategy or policy, because inevitably you will have people who initially have a chaperone or escort and then something happens, right? So we said, we know that policy exists. You may not want us to talk about it, but let's talk about it and let's figure out if we can kind of triage people in that way. And then I would say that the other things that helped was actually looking at coverage. So sometimes our healthcare center for these unaccompanied individuals will use taxi services. The taxis are exorbitantly expensive, and we looked at their insurance coverage as well, which is also not great. And so here we were able to show data for, and we got this from the rideshare company, just on average how much rides cost, and then also their insurance policy coverage, which was 3 times the coverage from the taxi companies. So we sort of used all of those data points to make the case for why we should allow these patients to go through the unaccompanied chaperone strategy. And then I would say probably the final point we made was around being able to track these individuals from the point of departure to the point of arrival, which you can't do when patients are released to somebody else that you don't know. Does that answer your question?
Yeah.
Some questions over there.
For the group that you covered their extra out-of-pocket expenses.
For the super screening program?
Yeah.
Yeah.
What was the ballpark that was covered on average per patient? Because that would be helpful to know. It was big household people.
It was really small. It's like $25 to $30. So these are people, again, when they were declining, we were initially concerned that this would be a huge expense. And there are other similar screening programs that actually exclude insured individuals because of this reason. But we really wanted to make sure that everybody had equal access to the screening program. So we said, okay, let's just put this pool aside for a year and let's see what happens. And the average cost was $25 to $30 per person. And most of them are negative as far as their results. They're not going on to cancer treatment. And again, for those that do get diagnosed with colon cancer, we're able to plug them into existing financial navigation programs, which exist usually in all cancer centers. Yes.
Yeah, just a quick question. The petition or the application you put in for the universal platform for to track screening, was that on the national or the state level?
Oh, state. That was a recommendation we made to the state legislation, but I don't know.
How realistic do you think it will be to be put into effect?
I don't know. I would hope it is, but it's an election year and I feel like it's like late, so nobody wants to do anything dramatic. So, I mean, there are great advocates for colon cancer in my state. Jason Dominitz, who directs the colon cancer screening for all the VA systems. Bev Green, who's an internist and has done amazing work in colon cancer. So these are the people that, I was on the committee with and, making these recommendations. I hope the state listens, but.
Great presentation. Dr. Isaaka, I have a question. How you can tell us more a little bit of how you overcame the barriers with regards to bowel prep? What prep was used, whether it was an issue with taste, like, likely, or was there a specific instructions given to patients to increase compliance?
Yeah.
For bowel prep?
We haven't specifically addressed bowel prep yet. So all patients get uniform kind of instructions from the endoscopy centers. We try to address it in the video for the fear specifically, and the way that we address that kind of using behavioral health tactics is just showing somebody who looks like the patient population we're trying to reach and their experience of like going through it. We've had, certain populations, for example, our Muslim populations and also some of our East African patient groups where the patient care coordinators tell us about how important like cleanliness and like the cleanse is. So that we try to incorporate some of those messages for those specific groups and the materials that they receive. But we so far haven't exactly examined the specific question about prep.
What kind of prep was used predominantly?
Go lightly.
Go lightly?
Mhm.
Okay.
Yeah, we have, and it's interesting depending on the site, because, we screen at our cancer center, we screen at the safety net, we screen at our main hospital, and you see variations in like who takes more Mobi prep or Sue prep, et cetera. I personally believe Go Lightly is the best prep. And I've taken it before, so I tell my patients, it's not that bad. Add a little Crystal Light, let me chill it.
I took Miralax.
You took me like, I'm here like Gatorade.
USF recommend, I did my USF, they recommend,
You did Miralax in the Gatorade.
Miralax prep, yeah.
Okay. That's a good one too.
510 in 120, 510 grams.
There you go. And I had a 9 on the Boston.
No, yeah, but good day.
Yeah.
Yeah.
No ice though, right?
No ice.
Yes.
Didn't have an issue getting to the center to have a colonoscopy. Was there like a full analysis of that?
Yeah, we asked people how they got there. The majority of people either would walk or they would take public transportation.
Okay, and then it was mostly just the issue.
Yes.
Like not necessarily getting to the interview there.
Exactly. Yeah.
You had about 9,000 patients that you studied initially. I think it was slide
The first
19.
year.
And then 31% of those, or I guess 9,000 were eligible for a colonoscopy. How many of those patients actually had a primary care provider established for them to then subsequently get the results and, kind of close the gap?
Yeah, all of them. So that group, that 9,000, there were actually initially 20,000 people that were eligible and due for colon cancer screening at that time. The other 11,000 we thought were not really most suitable for males outreach because of either comorbidities or prior history of other indications. But we just thought that the 9,000 was the group that was most primed to respond and most appropriate for the fit. So all of them were had been impaneled or had seen a primary care, had a primary care encounter in the past 3 years. Mhm. Yeah.
And for those that did not respond, because I remember you saying 9,000 and 3,000.
Yes.
When did the PCP reset to try to offer again the screening later of that?
Yeah, so what, the way our program works is, people get the mailer. Every 2 weeks for about 3 or 4 times, they get reminders to do the test. After like that 8-week period of reminders, if they haven't done the test, that list goes back to the primary care provider. And they can decide on what strategies they want to use to better engage those patients. Often that list will go with an upcoming visit. If somebody has an upcoming visit, to sort of flag them, hey, this person is going to be coming in the next month if you want to have that conversation around colon cancer screening. And then each year we kind of revisit with the primary care group to say, like, how can we better support you in this process? Our navigators, in addition to that, are also looking at healthcare maintenance tabs and Epic Care Everywhere. And so some of those people who don't ever complete the fit, it turns out that they've gotten screened somewhere else. So then our navigator will update the healthcare maintenance tab so that it's credited to the primary care provider.
Kat.
Yes.
How do you decide to have the primary providers be the primary driver for moving patients through the process rather than have the navigator help the patients and keep the provider aware of what is happening to their patients?
This was something that our primary care providers wanted to do. So when we started the program, we offered that the navigators would be the ones to see the patients all the way through. And our primary care providers really felt strongly about continuing to be engaged in that process. So actually in the first year, they asked that we not contact patients for 3 months after an abnormal result. And what we found was that most, and this is sort of true of the literature as well, is that the longer time passes, the less likely people are able to the less likely people are to complete that follow-up colonoscopy. So we sort of went back to our primary care partners and said, can we engage people within the first month instead? And they said yes, sort of seeing the settings where we were intervening early and the effect that we observed there. So I think our primary care doctors will always remain involved in that process, but having navigation really earlier now that's sort of what's led to that 16% improvement from people who just initially go on to do the colonoscopy by themselves.
And then the second one, how often is the FIT test not used appropriately in your patient population?
Can the person online elaborate on that question? Because I think we try to make sure that everybody who's getting it is appropriate, meaning if they've had polyps, a history of polyps, they're not getting a FIT. We can't screen for family history because Epic just doesn't do a good job of screening for family history. And so there are, again, that's why when they get that letter, one of the bullet points there is if you have a family history or if you're having symptoms, we say this is not appropriate for you. You need to call us to get a colonoscopy. But I'm wondering if they're trying to ask a different question. While we wait for them.
Age over 85, for example.
No, we do not include those individuals. We only include people who are 45 to 75 in outreach. Yes.
Do you provide any backup genetic counseling for those that are, high risk in young age or anything like that?
We do not. We leave that up to the endoscopist, like let's say if they find multiple polyps, but no. Our program does not do that. I would love a great way to scrub, maybe this is another AI tool where we could scrub the EMR for family history because that's really challenging to find for a population health program like ours. Thank you so much.
Thank you so much.